Good morning. We are going to get started with this very interesting, exciting session. A little change to begin with. Ivo is going to be the first speaker, and he will tell us about his 10-year experience with the use of Valiant Captivia for the treatment of aortic dissection. Ivo?
Dear Frank, dear Jacques, thank you for coming. Thank you for supporting our meeting. Aortic dissection, how far are we in the treatment? In fact, not too far. It's still one of the most deadly disease nowadays in the medicine at all. And there are many additional factors that can worsen the prognosis and worsen the results of the intervention. Still, the mortality by the classical surgical treatment is not neglectable, both for type A and especially for complicated type B aortic dissection. The intra-procedural mortality during surgical intervention, you see it's definitely around between 20 and 30% in many cases. The new recommendations are telling us that in patients with acute type A aortic dissection even without an intimate tear, it has to be performed not only proximal sealing, proximal treatment, but also partial arch replacement in order to improve the results. The problem is that the so-called tear-oriented approach is still the main approach in many hospitals, in many teams in the world. In fact, the pioneers of this treatment, Michael DeBakey and Denton Cooley, they put several methods, surgical methods on the treatment. And the tear-oriented proximal treatment that I mentioned is not sufficient in more than 30% of the cases. And at least 15% of these patients that are operated with proximal-oriented procedure will need a secondary procedure, secondary surgical or secondary endovascular. The redo operation results, unfortunately, are not far of being excellent, and the mortality is reaching 15%, and the stroke rate is reaching 20%. For example, in this big Chinese series of patients with total arch replacement as a secondary procedure after first operation for type A aortic dissection, there were cardiac complications of 18.2 and severe neurological complication 21.1%. Probably because of that, in the guideline is telling us that endovascular stenting instead of surgery, if anatomy is suitable, for repeat aortic surgery is indicated. Nikolai Volodos, in fact, is the pioneer to place the first homemade aortic graft for type B false aneurysm dissection. This is in fact the publication of Nikolai Volodos. This post-traumatic false aneurysm transection was covered by this homemade. You see here is the surgical graft mounted, sewed on two big palmat stents in the two edges. And on this way, he succeeded to introduce this surgical graft inside the aorta without opening the chest. Probably all these interventions and innovations led to mentioning the endovascular option even in the aortic arch in the last European guideline. You see here that in the treatment are listed hybrid or even endovascular in case the aortic arch is involved. So, but the problem of the aortic arch is that everything that is positioned, landed in the zone 0 and 1, and partially zone 2, has to be protected for cerebral vessels inflow provision. So we need techniques, surgical, like shown here, or hybrid, But unfortunately, the hybrid and the surgical procedures, they require again extracorporeal circulation and surgery. With the inherited complication rate. There are totally endovascular options like fenestrated and branched grafts. Many of them are still off-label, not on the market, not on the shelf. And because of that, we need some totally endovascular options that are always available. For example, large-size aortic bear stent implantation is one option. Brachiocephalic vessels chimney technique parallel to the aortic graft, or the last innovation is the in situ fenestration. We have, experience with all this. I'm showing a case with secondary intervention. In fact, a primary intervention at 48 very young gentlemen with aortic dissection, with uncontrollable pain and uncontrollable hypertension, with huge compression of the true lumen like shown here. And in this situation, we succeeded to implant. Sorry, could you help me with the movement of the slides? Next slide, if possible. From here, I cannot do it. Okay, so we implanted, as you see, we implanted a multi-layer flow modulator stent from the coronary arteries all the way down across the brachiocephalic vessels, all the way down to the renals. Следващия, ако може. Next. And the evolution, you see, this is on the ascending aorta. The beauty of the case was that between the 6th and the 12th month, you see the false lumen in the ascending aorta practically disappeared. So the patient was really treated very efficiently with this technology. Of course, it was an off-label case, but off-label, but now 8 years after the procedure, or already not 8 years after the procedure, the patient is doing very well. He's back on work and absolutely normal way of life. What about other totally endovascular options? These are the chimney techniques. With the utilization of the Valiant Captivia, we have more than 100 cases with the utilization of Valiant Captivia for aortic dissection, both for type B and type A dissection. And Valiant Captivia is very well controllable because of this tip capture control deployment, and it's very nice device. This is our aortic activity during the years. And this is the cohort of 138 patients with aortic dissection and aneurysm, and 101 patients were with aortic dissection. In 37% of these patients, we applied chimney or in situ fenestration. The chimney technique is very well known, with quite a good and large experience during the years. Our experience comprises 18 patients, 4 with 3 chimneys, 7 with 2, and 7 with 1 chimney, with very successful result. This is a patient, 57-year-old male, operated for type A aortic dissection with implantation surgical graft. Unfortunately, like in many cases, he has continuing dissection after the surgical graft. You see the flesh over there. And we decided as a secondary procedure to perform direct carotid puncture without cutting anything, and even without general anesthesia. You see there is no intubation tube there. This is the position of the chimneys from the carotid and the brachiocephalic trunk by endovascular approach parallel to the aortic graft. And this is the final result after the completion of the study, with very good imaging and clinical evolution. The other option, let's say the most innovative and up-to-date option, is the in situ fenestration. We are going to perform today a very similar case, a patient that was operated 2 years ago for type A aortic dissection, with huge growth, unfortunately, of the false lumen, because the additional tears in the aortic arch, and the false lumen is nowadays already 56 millimeter. That is very, very big, and the true lumen is very small, and because of that, this will be our live case today in approximately 1 hour and a half. In fact, this is our experience during the last almost 2 years, 19 patients. This is our protocol. In fact, the essence of the protocol is first the extracorporeal connection of the femoral artery with a big sheet to the carotid and brachiocephalic trunk, extracorporeal bypass, that after implantation of the aortic graft, because of the pressure gradient, the blood is coming from the femoral to the carotid arteries. This is one. And the other one is that we are using for fenestration the electrified astato metallic wire, not hydrophilic. And you see, we are going to see the blood coming. You see the blood, how it's coming through the tubing, going up to the subclavian and the carotid artery because of the pressure gradient. And we have measured the pressure in the carotid and the pressure in the femoral. We are, in fact, providing around 75% of the pressure, systemic pressure is provided for the brain. That is very close to what is the extracorporeal circulation can achieve. And this is cutting the tip of the wire in order to be even more aggressive, and connection to the electrocautery. This is the connection to electrocautery. It's a case, very complex case. The lady was operated for type A aortic dissection and huge aortic regurg. She had aortic valve replacement and ascending aorta replacement with possible secondary implantation of Medtronic Captivia, Valiant Captivia. We implanted. Unfortunately, obviously, we didn't implant the stent on the good landing zone. You see there is in fact endoleak that is unfortunately filling. This is the endoleak filling the false lumen, and we had to proceed with a third procedure. And we decided to make a prolongation of the landing zone toward the surgical graft, to use the surgical graft as a landing zone, and to make fenestration of the Valiant thoracic implanted on the landing zone. And this is in fact crossing. You see how the wire is crossing the fabric of the Valiant Captivia. And after crossing it and enlarging the fenestration with 1.5 millimeter balloon, after a 2 millimeter, 3 millimeter, 4 millimeter, 5 millimeter, and after reaching 5 to 6 millimeter, after externalization of the wire, you see, lasso, snare, in order to externalize the wire and to have very good support in order to implant. This is ballooning of the fenestration. After good ballooning, good predilation, we implanting the bridging stent, big graft, and this is, you see, the big graft is already implanted for the brachiocephalic trunk, and we did the same for the other brachiocephalic vessels, and this is by the subclavian artery, the implantation of the stent, and this is the final result. So you see that the flow is restored in all the brachiocephalic vessels. And this is disappearance, total disappearance of the endoleak into the false lumen. No more endoleak. You remember probably here there was a stain, but there is no more endoleak. The clinical evolution was very good. Okay, in order to short everything, in fact, we need definitely innovation in this field, and there are many companies making now fenestrated branch grafts. Many of them are under investigation, but until the full proof of these new devices. The in situ fenestration is always available procedure, and especially in emergent cases and complicated cases is one of the good options together with the chimney graft strategy for type A and type B aortic dissection. Thank you very much for your attention.
Thank you, Ivo. Can I ask you one question? It relates to the multi-layer stent. You know, with such incredible capabilities, especially for the acute and subacute stage, where, as you showed, you can cover the entirety of the aorta, covering all of the branches and so forth, how come, after so many years, it hasn't become the dominant therapy?
Yeah, in fact, still the MFM is still off-label for aortic dissection. This was a compassionate case, off-label compassionate case, and Victor Kostaki this afternoon will show their series for dissection. And we participated together in a trial for type B aortic dissection with very good results.
But you know, 8 or 10 years ago, many of us would have anticipated that, oh my God, this is going to be the one. Yeah. It's going to kill every other option and product, but it hasn't happened.
Yeah, unfortunately, they didn't succeed in aortic aneurysm. And the main indication and the
but even dissections.
In dissection, probably because it's still not a good large trial. There is still not a good large trial. And we are in the extenso trial included. The extenso trial is to apply the petticoat strategy. So to implant a stent graft as a sealing, proximal sealing and prolongation with
one of the reasons of this failure was the lack of marketing from the company to the authorities. Absolutely. In US, in Europe, they were a little bit soft. So they were not aggressive, lack of money.
Well, not the lack of marketing, it's because it was all marketing. The lack of science is what you're talking about.
Exactly.
Yes.
This is the problem. The lack of science and the not good results with aneurysms. And because of the compassionate cases that we have done, mainly Victor Kostaki and my team, we have done several compassionate cases during the years for aortic dissection with no more options. Right. And we had very good results. With
they try the new company, Interesa, start something new.
Yeah, this is the extenso trial.
Yeah.
Extenso trial.
Thank you very much.
Thank you.
We'll see you later with the live case. So, Jaques Busquet is going to be next, and he's going to talk about the continuing mystery of endotension.
Thank you, Ivo, for your invitation. May I have my slide, please? Thank you, Frank Riado, Dr. Donna Reed, and myself are former president of the ISCVS. The ISCVS is still very active from Houston, Texas, and we are managed by the Journal of Endovascular Therapy, and we work with chapter Think Global and Act Local. So there are several chapters in India, in Abu Dhabi, in East countries, maybe elsewhere. So I'm very happy to be the ambassador.
Don't go to Abu Dhabi
Only
right now.
only a one-way ticket. There is a mystery regarding this type of endotension. Maybe the most senior, you have been involved in such a case, and I would like to speak of my experience. You know that aneurysm need surgery or endovascular technique, but sometimes you have this kind of complication of mystery that I would like to speak about. What is endotension? on this schematic drawing, it's an hyperpression inside the sac, and sometimes you don't know the reason of such hyperpression. What is the occurrence in the population? Only 1.6% searched by Cicala from Parma, Italy. So it's not so often. Anyway, what are the potential etiology? Fabric porosity, fluid accumulation, like a natural process, or an intermittent endoleak to be searched, because you need a reliable method of investigation, and probably CTA is the most able to do that. Which are the treatment from the literature? Open surgical conversion, it's used 30%, but it's very traditional, open surgery made by people of the team. Conservative approach could be risky. Endovascular relining, interesting solution, or semi-conversion, that you keep something during the open, you keep something from the former graft. The success is good, between 80 and 90%. There is an enigmatic complication, the endotension. So can we solve that? Always look behind you when you are a leader. This is the importance of this story. A geography for you. We go to Prince Alfred Hospital in Sydney, Australia. We've been there. Frank, you, Lydia, no? Me, we've been there. And I found these two guys. Jim May, a good friend. He discovered a lot of things. With Jeffrey White, Australian, they did the classification in 1998 of the endoleak. Remember that, because they create this typology. I was honored to give an ISCVS Award of Honor to Jim May in 2019, and this is the picture with Ramon Varco, one of a former fellow, and Jim May and myself. Geoffrey White was a good friend of mine. He was a very nice and intelligent guy. He was always try to find something new. He got a lot of things to be in application in the reality of medicine, but he died of melanoma very early, too early. He was working on the endotension. He said that it could be a low-flow endoleak. Let's go to England now, to Liverpool, with the new hospital. There is the old hospital and the new hospital. In the old hospital, Jeffrey Gillian-Smith, a very nice guy also, who died too early on the operative table of repair of aortic valve. And we lost him. He was the one who invented the term of endotension. Persistent pressurization of the sac. It was simple, but he did it. He was a good friend of Dr. Dietrich. He was a good friend of Dr. Castellani, who were working in Ajaccio, who organized in Ajaccio a very interesting meeting on the beach with the sea. But it was a good, you've been there, Frank. you remember. It was a good time, but it was the question of interact together and try to find the best way and new solution. So we have a classification of endoleak right now, you know it. Endotension is number 5. So there is a question, is it a myth or reality? Some hypotheses. Undiagnostic endoleak, intracircular hygroma, transudation of fluid, or undergraft infection. Harry Menader said it was possibly a graft infection. I'm not sure personally that is the right reason. Sometimes you can be helped by wall stress distribution to see where is the pressure. And Dr. Oki, one of our friend from Japan, but he was working during 15 years in New York, in Montefiore. He explained that the original excluder was too porous, and they corrected. So it was a fabric defect. So sometimes I like to do relining. You can do down, medium, or high. And on this example, you start with 56 and you finish, despite the treatment, at 78. Sometimes you have to do a surgical conversion. You see what is inside. Jaques Busquet invent that sort of sensor, not used anymore. And Dr. Wyss write a book on endoleak, so it's something important. Christopher Zarin, a former president of ICVS, said that could be associated with an angulation of the proximal graft. And it was one of my cases, a little leak, but a 5 millimeter migration. So we put a curve to correct. So what are the recommendations? Look for invisible endoleak, proximal migration, or neck angulation. And our good friend, also from Stanford, Venita, had some recommendation. Close surveillance with intensive search for endoleak, treatment of patients with significant sac enlargement, and a phrase that I like, aggressiveness of the intervention should be determined at the discretion of the surgeon. So in conclusion, when endotension is suspected, long-term follow-up, vigilant imaging, and ultrasound, CTA, MRI, and close surveillance. Thank you very much.
Thank you, Jack. So next we are going to go with Mr. Reed on the subject of, no?